This is the 2013 Professional Rescuer CPR for Clark County EMS. This presentation is intended to augment your annual CPR training that you receive from your department and for the healthcare professional. This demonstration reflects most of your protocols by the MPD for cardiac arrest methods in Clark County, but not all of them. Science now knows that immediate, uninterrupted, and properly performed CPR saves lives. We know how to do CPR. We must now close the gap between knowing how to do CPR and the way we actually perform CPR. Providers now have more opportunity than ever before to improve survival from sudden cardiac arrest. The focus must shift from do CPR to do CPR right. What separates the Clark County community from most successful arrest survival rates in the country is effective bystander CPR efforts. We must share our knowledge of CPR with our community, family, and friends to improve the outcome of out-of-hospital cardiac arrest survival. Our focus remains on the key points of high-quality or high-density CPR. Science continues to confirm this philosophy. Compressing the adult chest at least 2 inches for every compression delivered. Full chest recoil, meaning that the weight of the compressor is taken off the chest after each compression, allowing the heart chambers to fill to capacity. This does not mean, however, that the hands come off the chest. No bouncing. Maintaining the compression rate of at least 100 per minute. A compression rate of 100 to 110 is ideal. For the use of this video, use the Clark County EMS skill sheets labeled Professional Rescuer CPR. Here we see a crew approaching the patient. BLS personnel are at the head and chest area, while an ALS medic can assist with getting out the fast patches and applying them to the chest as needed. We'll watch the first 1 minute of the resuscitation play out and then repeat it to highlight some key points to focus on. Notice the compressor does not hesitate for ventilations. Compressions continue at 100 plus per minute, and the ventilator ventilates 1 breath every 10 compressions, interposing ventilations with compressions. A very important step that still is being occasionally omitted is when to turn on the cardiac monitor. The monitor must be turned on when compressions begin. So why is this step so important? Here is a PCO file that was downloaded from a cardiac monitor used during a cardiac resuscitation. The data managers at ROC, at OHSU, have already annotated or cleaned the information to reflect an as accurate as possible record of the event. This graph depicts this valuable data that represents a scorecard of how the crew performed. This is not a disciplinary report for actions to be taken against crews, but rather a way to identify training issues or confirm to the crews that CPR was a priority. Several of the gauges are not displaying any results. That is because the monitor was not placed in the AED mode, and ventilations tracking has been disabled. The power on indicator shown here tells the data managers when CPR actually started, even though no tracings of the chest compressions are being recorded. This is due to the fact that the fast patches were not applied yet. This was not accomplished until about 2 minutes and 10 plus seconds after the monitor was turned on. CPR ratio percentage and compression ratio percentage are nearly the same. Compression ratio is the percentage of time that the crew spent performing compressions over a total time. The monitor records this period as between when the monitor was switched on and then turned off. So a 50% compression ratio means that the crew spent half of the time when the monitor was switched on doing compressions on the chest. ROC data managers excludes periods of ROSC, or return of spontaneous circulation, which can drive down a CPR ratio. High-quality CPR ratios are 90% and above. Compression rate is the rate as an average over a given period, often over several minutes or an entire call. So if you have clusters of compressions during a code, rarely are they uniform across the entire code, the rate would be the overall average speed. The monitors use the raw count, compressions per minute, to calculate rates. Rates adjust for the normal variation in compression speeds throughout a call. A good rate, of course, sits at around 100%. Compressions per minute. This is the raw count of the number of compressions in a 1-minute period. The bottom line is the literature supports that the best CPR is performed at a rate of 100. The higher the CPR ratio, the better. CPR ratios can be maximized by no peaking, continuous compressions, and low pre- and post-shock pauses. These are the operation components which CPR stresses for all crews. The reason we monitor CPR quality for ALPS is to determine that the drugs, and not poor CPR, are affecting the presenting rhythm. To emphasize how the BLS crew owns the code by continuing compressions while an ETT is attempted. Demonstrated here is the use of a bougie device instead of a stylet to facilitate the placement of a tube while uninterrupted compressions continue. This way, ALS can take more time to visualize the chords without ventilations as long as chest compressions continue uninterrupted. An acceptable trade-off. For those instances where an all-BLS crew performs the initial steps of resuscitation, the next clip will demonstrate the steps of using an AED with minimal chest compression interruption. Like the ALS version of this, the compressor calls out 180 to alert partners to the approaching 200th compression. At approximately 190, the EMT at the AED pushes the Analyze button, allowing the AED to begin the assessment without us waiting for the machine. At 200, the EMTs rotate the compressor position, allowing the AED to analyze the rhythm while no movement to the patient is occurring. Chest compressions resume while the monitor begins charging. The crew is cleared away before a shock is delivered, and chest compressions begin immediately after the shock. Because as healthcare professionals, you may or will be asked by laypersons about CPR standards for the public. They are indeed different from what we are doing as professional rescuers. This portion of the video will cover those guidelines established and recognized by national organizations. When you are out of uniform and acting as a layperson, you will need to interface with the standards taught to the public. The chain of survival is represented by the links above. Every link is critical to out-of-hospital cardiac survival. They are early recognition and activation of the 911 system, initiating high-quality CPR, delivering an AED or ALS next to the patient's side as soon as possible, ALS intervention and transport, and finally, delivering that patient to an appropriate facility capable of inducing hypothermia treatment and cath lab capability. The ABCs have also been replaced with CAB. This places the importance of chest compressions first, rather than opening of an airway and giving breaths. The only time mouth-to-mouth is being suggested is to a family, friend, or child, or when a barrier device is being used. Otherwise, hands-only CPR is emphasized until additional equipment is brought to the patient's side or trained help arrives. Community CPR, or layperson CPR, has undergone some changes with good intent and successful results. The public is now taught to look for signs of unresponsiveness, not moving, not responding to shakes and shouts, and if they are not breathing or abnormally breathing, which are gasps and grunts. If they believe the person is not breathing, then they immediately go to expose the chest and place their hands in the center of the chest and begin compressions. They are not taught to assess a pulse. They begin with chest compressions and are told to push hard and push fast. It is important to note that they are not taught to check for a pulse, mostly due to the fact that they are terrible pulse checkers, as well as a lot of professional rescuers. Performing chest compressions on a person with a pulse is not detrimental to the heart itself. Ribs could be cracked or broken, resulting in further or potential injury, but not the heart. Anytime you, as a professional rescuer, have the opportunity to share your knowledge of life-sustaining gift of CPR, please take that opportunity and get someone trained, or at the very least, direct them to an organization or a site where they can become more informed and trained. In summary, the emphasis in this presentation is to perform high-density CPR. This is accomplished through maintaining a compression depth of greater than 2 inches, performing full chest recoil, and maintaining a compression rate of greater than 100 per minute. Also, resuming chest compressions immediately after each shock or when an analyzation says no shock is advised. If the BLS team owns the code, this will ensure that high-quality, uninterrupted chest compressions will be performed, maximizing the patient's chance for a positive outcome. Remember, push hard, push fast.